My name's Professor John Terry, and it's a great pleasure to chair this next session, which is looking at patient data research, or another way of thinking about it. This morning, the first session we heard about animal models, the second session we heard about clinical models, and now we're going to hear about sort of data-driven models and think about what these can tell us about epilepsy. And it's a great pleasure for me to introduce our first speaker, Dr. Catherine Bush, who will be speaking about understanding patient data in epilepsy. Now, Dr. Bush is a public health registrar, an academic clinical fellow and neurologist based at Newcastle University. She began her career in data science and will shortly be beginning a research project which aims to investigate inequalities in epilepsy across the UK, seeking to understand if population-level interventions can help prevent epilepsy-related deaths. So, Catherine, when you're ready, over to you.
Thank you. Hello, everyone. It's a great pleasure to get to come and speak to you all today. And what I'm going to be doing is just giving you a very brief overview about understanding patient data. So what it is, what we can use it for, and why it's so important. So we'll start off with what is data research. So patient data research is research that's performed using any type of information that's collected as part of routine care or data which is specifically collected for research. And I love these two photos on here because these photos are both at Cancer Research UK and they're taken 60 years apart. But although the technology has moved on and the processes have changed, the concept is the same. It's about using patient data to try and improve health and improve lives. And data comes in many different shapes and sizes. So when we talk about data, or when I talk about data, I'm talking about basically anything that your medical visits or your medical records might generate. So that could be your prescription data, genetic tests, MRI reports, ambulance records, if you're a smoker, what your BMI is. There are so many different things which make up patient data. And we're going to talk about two main types of, I've changed it from patient to person data, and that is two types of data which we can use in research. So on the one hand, we have data which is collected specifically for research. So that type of data would be generated if you sign up to a clinical trial, if you're in a cohort study, if your consultant asks you to fill in a questionnaire, if you're in a registry. So it's generated specifically for research and used for research. The other main type of data is routinely collected data. So this is the data that's generated whenever you have an interaction with a health service. So on a kind of straightforward level, it's your medical record. That data exists as both a physical record in a hospital, and it used to be paper, nowadays it's electronic, but it also exists as a list of codes. So when you go to see the doctor, so imagine you have a road traffic accident and you go to A&E. In A&E you'll get a road traffic accident code. You might end up going to intensive care, then you'll get an intensive care code. And then you develop epilepsy from a head injury, and epilepsy goes onto your coded data. So I don't need to look through your medical records to know that's what's happened to you. I can just look at that list of codes, and that list of codes tells a story about individual patients, and it tells us a story about populations as well. So why is it so valuable? Well, it's a really, really precious resource because data just really holds the potential to understand diseases and populations, and we can really use that data to try and improve healthcare and improve services. So I just want to focus for a minute on why routinely collected data is so important. So trial data, clinical trials, cohort studies, is exceptionally important. The only problem with them is they're often quite small. They're often limited in size due to costs or due to the numbers of people that can be seen. The other thing that we know is that the people who sign up to be in clinical trials, the people who are in cohort studies, the people who fill out questionnaires, are different. Those people are not the same as the general population. The general population doesn't do those things. So when we do clinical trials and we have those people involved, it tells us a lot of very good detailed information about that small group of people. But it doesn't tell the whole story. So it doesn't tell you about Auntie Ethel, who's 90 in a care home with dementia. It doesn't tell you about a lawyer who's working 500-hour weeks, I don't know. It doesn't tell you about a single mum with 2 children and 3 jobs and no car who can't get along to clinic appointment. So the joy or the beautiful thing about routinely collected data is that it involves everyone, includes everyone. So when we look at it, we can get the whole picture. The other thing about it is that it can be linked. So medical records, hospital records, GP records, A&E, death registry data can all be linked together. So it's not just telling us about one very small area of people's lives or one small area of activity, but it's giving us a bigger picture. And it also can be kind of lifelong as well. So what can patient data be used for? I'm going to rattle through this list. So it can be used to improve the care of individuals, populations, safety, diagnosis, services. It can be used to develop new treatments. It can prevent disease. It can help us to understand diseases, risks and causes. And it can be used to evaluate the impact of new policies. And I rattle through that because you lot already know that, because you've seen it in action. I'm going to talk about that in just a minute. But before we go any further, I'm just going to address the elephant in the room. People worry about their data and they worry about how it's used. I worry about data. I worry about how my data is used. The thing that I've learned is that actually medical research using patient data is not what you need to be worrying about. You know, Google know that I'm in London today. My mum doesn't know I'm in London. My husband thinks I'm in London. But Google knows I'm here because it's tracking me with my phone all the time. And I've consented to that in downloading, you know, Google Maps onto my phone. But I don't think that patient data is the same. So there are so many things that are done with patient data to make sure that it's kept safe, secure, and confidential. So for a start, all of your kind of easily recognizable details are removed. So people's names, their dates of birth, or addresses are removed. And the next step, I actually think, is the most important. So when you apply to use data, you go through extremely rigorous checks as a researcher. So they don't just hand out your data to anyone, thankfully. They make sure that the institution you're coming from is a responsible and reasonable one. They check your qualifications. And I don't think, having been through the process now, that you need to be any more worried about patient data in this way as you would when you go and see a doctor and you're given your information to a doctor. Because I know, having worked in clinics, you know, I'm not going to take your notes home with me. I'm not going to do anything wrong with your data. And to make sure I don't, there's also legal protections in place. So whenever people use data, they sign contracts, and its use is governed in the UK by the Data Protection Act and GDPR. We've got secure systems, controls, penalties for data misuse, and really importantly, people can decide to opt out. So if you decide that you don't want your data to be used at all, you can opt out. So, I said before that you all know what data can be used for. If you're sitting here today, you have survived the COVID-19 pandemic, but you've also experienced a revolution in data science, because the COVID-19 pandemic has driven data sharing and the use of data. All of the barriers that were put up came down for COVID, and that has left us in a really exciting place. So in the COVID-19 pandemic, you saw real-time data every day when you saw how many deaths there have been, how many hospitalizations, how many ITU cases published on the government website. This is just a government slide. You were seeing what real-time data can do. And that data was being used behind the scenes by the government, by the health services, to monitor the cases, to look at vaccine uptake, to assess vaccine safety and side effects, and also to look at the impacts of lockdown, so to look at the impact of policy, because we saw the deaths went down. The other thing that the COVID-19 pandemic allowed us to do was to think about who was at risk. So it allowed stratification. There was access to data about age, obesity, ethnicity, which allowed us to understand who was at risk and tailor care effectively to those at-risk groups. So how does this all relate to epilepsy? Well, this is a previous piece of what we call big data epilepsy research. So this is some work that was done by Owen Pickrell, who's a neurologist in Swansea. And what he looked at was how common epilepsy was according to the levels of deprivation where people lived. And it's a little bit hard to see, but if you look on this slide, the graph closest to me, in the least deprived areas, epilepsy prevalence is less than 0.5%. So less than 0.5% of people will get epilepsy. In the most deprived, it's over 1%. It's getting close to 1.5%. So there's a big difference. There's over twice as many people in the most deprived areas are getting epilepsy compared to the least deprived. And this is what we call a health inequality. And health inequalities are systematic, unfair, and unjust differences in health between different groups of people. And really importantly, when you can demonstrate a health inequality, your next step is to start thinking, what can I do about it? And what we're going to do about it is perform this piece of epilepsy research, which was referred to, trying to understand why epilepsy is more common in the most deprived areas of the UK and why people with epilepsy are more likely to die early. And we're going to take a population-level, data-driven approach. So we're going to use national data sets of coded data to really paint a picture and try and understand who has epilepsy, why do they have it, what are they dying from, and really importantly, which cases of epilepsy could be prevented, which epilepsy deaths could have been prevented. Because I believe that we need to move this focus and start making prevention a priority in epilepsy. Once we can see the full picture, we can start to work with people with epilepsy to work out what we can do about it. We can use the data we've got and model what might have the biggest impact on changing people's lives. And we can target interventions to try and prevent epilepsy and prevent premature deaths. There's this really powerful quote by Desmond Tutu that said, "There comes a point where we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in." And that's what I really believe data research can be used for. So I've just put a few quick links there about where you can get more information about understanding patient data. If you want to, the top link there, understandingpatientdata.org.uk, is one that's been put together by all the kind of major funders, by Wellcome, NIHR, and has loads of really good information. There's also the NHS link there, which tells you about what the NHS is doing with your data and has the opt-out option if you wanted to take it. Thank you. Now we're going to move straight on to Professor John Terry, who will be answering the question, can mathematical modelling improve accurate diagnoses? Professor Terry is an interdisciplinary professorial fellow at the Institute for Metabolism and Systems Research at the University of Birmingham. John's research transcends traditional discipline boundaries, speaking to mathematics, computer science, physics, biology, as well as biomedical and clinical sciences.
Thanks so much for the introduction, Catherine, and thanks to all of you for attending. So as was mentioned, I'm going to now talk about mathematical models and can we improve diagnosis. So we're going to move from population level modelling to thinking about individuals. And I guess the idea this morning, we heard about potential new treatments, but how do we actually identify who are the people who need those treatments and whether or not those treatments will be effective? So hopefully that's what we'll cover off. But before we do that, I should disclose that I'm a co-founder and managing director of Neurognostics, which is a startup developing clinical decision support systems for neurological conditions and in particular epilepsy. So when I talk about this work, do bear that in mind. And just to give a brief overview, I'm going to introduce what a mathematical model is, ask the question why mathematically model the brain, and talk a bit about the relevance to epilepsy diagnosis. So the dictionary definition of a model, and that could be any type of model, animal model, clinical model, mathematical model, is a simplified description of a system or process to assist calculations and predictions. And extending that to a mathematical model, it's saying that it's a model that's built using equations, so some maths somewhere, approximations, and assumptions. So we're going to assume certain things. And as a result, lots of people have made observations on mathematical models, and I'm going to just provide a few of these observations and see which one you feel most comfortable with. So it was Norbert Wiener who back in the 60s, maybe even the 50s, said that the best material model of a cat is a cat, and preferably the same cat. Basically saying if you want to model something, take that thing and just look at it. But on the other end of the spectrum, Einstein said a model should be as simple as possible, but no simpler. So that's going to the reductionist approach, but also saying you shouldn't reduce too far. And how do you know if you've gone too far? That's an interesting question. As Box once put it, all models are wrong, but some are useful. And as a clinician in the States updated that, all models are right, but most are useless. So where in this whole spectrum of approaches to modelling do we sit? Well, first of all, let's focus on that very sort of high-level approach that Wiener proposes, that is that the best material model of a cat is another or preferably the same cat. And we can update that in the context of epilepsy. So if we updated it, it would say that the best material model of a human epileptic brain is another, or preferably the same, human epileptic brain. But I just want to unpack that a little bit in order to emphasise why actually mathematical models have just as much face validity as other approaches, because that's often a slightly controversial statement. So taking this at face value, let's imagine that we've got identical twins, so a genetic replica of an individual. So that's really the best material model we could have, because it's effectively the same person. Now, there is a genetic association with epilepsy, but it's not that strong. So on average, if you look at identical twins and one of those twins has epilepsy, the other twin won't have epilepsy. So if we're using the other twin to model the twin of epilepsy, that's not a great model. But Wiener said, preferably we have the same cat. So okay, so let's ignore the identical twin and just focus on the individual themselves. But in this case, we know that it's possible to have both epileptic seizures and non-epileptic seizures, and the same person can have both. So if we only focus on one aspect of their condition, we miss other aspects. So even using an individual as a model of themselves may not give us the full picture. And this is what we mean about models and the assumptions that underpin them. We need to understand holistically these things in order to be able to decide whether the model that we're taking is useful for the question that we're seeking to answer. And this is why I'd like to introduce some of the approaches we've been taking to mathematically model brain data and to see whether that can actually answer questions in terms of can it help with diagnosing epilepsy or other non-epilepsy conditions. So how do we mathematically model the brain? Well, as we heard this morning, the brain consists of about 10 to the 12 neurons. There's about 10 to the 4 connections per neuron. This is enormously complex. But actually, when it comes to epilepsy diagnosis, one of the most common tools we use is a device called the electroencephalogram, which measures aggregated electrical activity and produces signals like this. So this is about 10 minutes of data. And what you see in this recording is occasionally there are these high amplitude bursts of activity. See if I can use this pointer without screwing things up. Yep, there we go. Here, here, and here. And these are what are called spike wave discharges and a hallmark of certain types of epilepsy. So how do we model it? Well, we need a mathematical model, and I am going to put an equation up. And I propose that we can reduce the brain from all this complexity down to this single equation, give or take. And the reason I propose that is because this has a particular mathematical form, and essentially it enables the coexistence of two states, one of which is a kind of a low amplitude state, which mimics the interictal regions of the EEG activity, and the other is a high amplitude oscillatory state. And by playing around with these equations, we can enable transitions from one state to the other and back again. And I've obviously deliberately chosen model parameters carefully so that the output of this model really does look really like the EEG we see. But of course, EEG doesn't exist in isolation. Often you have 19 or 20 channels, so electrodes placed at different locations on the scalp. But you can have, in some research contexts, up to 256 of these things. So if we're going to model that, we need a big mathematical model, right? And so actually, though, my point here is that we don't need to make it too much more complicated. What we do is we have an equation like this, underlying the behaviour at each electrode, and then we couple them together by saying there's some way that brain regions communicate with each other, and we can either decide that way mathematically, or we could infer it from the data we collect, and then make the mathematical model specific to the individual from where the EEG was recorded. So what did we do with this? Well, we introduced the concept of brain network ictogenicity, and that sounds a bit of a mouthful, but basically what this is a complex way of saying the ability of a given network to generate seizure-like activity. So let's just play with some examples. So here's a simple brain, like my brain. It's just got 4 regions, A, B, C, and D, and I've set up the equations, and I simulate them over time. So here's an hour's worth of recording. Takes about 5 seconds to simulate on a computer, but I get an hour of simulated EEG out of it, and I don't see any pathological activity, so I would describe this as a normal brain network. Its ability to generate seizure-like behaviour is low. Now, interestingly, if I just change something very slightly, so this is exactly the same system as we had here, only I've just made region B ever so slightly more excitable than it was before. And now all of a sudden I can see pathological bursts, but really interestingly, I see them across all regions simultaneously. Now, this is an interesting observation because we heard a bit this morning about focal, generalised, different types of seizures. So this idea that, you know, a seizure originates in one particular region is shown here, but actually the activity can propagate everywhere depending on how these other connections, how the other regions of the brain interact. And we see a few bursts here, so we say, okay, this network has a medium ability to generate seizures. And then finally, I do something else. I start with my original network, but this time I just remove a connection between A and B. And then again, really interestingly, I see bursts across the whole system. And now this time, this is sort of saying, oh, okay, what happens when you sort of cut some connections? So all of these regions are the same. Not one of them's pathological per se, but the structure, the whole, the network, the regions together, interacting in such a way that actually seizure-like behaviour can occur, and actually it's really easy to occur. We see lots of bursts. And I guess the main take-home message here is that subtle changes in the properties of these brain networks have a significant influence on the ability of that network to generate seizure-like behaviour. And those subtle changes could occur at the cellular level, the genetic level, etc. So it's really important to think about how those cellular level mechanisms manifest at the network and how these make seizures more likely. So what's the relevance of this to epilepsy diagnosis? And this is some of the work we've been doing with neurognostics. Well, we take an EEG recording that someone suspected of having epilepsy has had collected, say at a first seizure clinic or a follow-up to that appearance at a first seizure clinic, and EEG is inconclusive. Many of you will have experienced this, that about 70% of first seizure clinic EEGs are inconclusive from a clinical perspective. So we take short segments of this apparently normal EEG and we use it to inform these computer models of the brain, and then we simulate the models on a computer over time. And the advantage of this is that rather than having to collect EEG data in real time, we can simulate that data for as long as we want on the computer. You know, we can get a year's worth of data in a matter of minutes, and we can see what happens if we change different properties and understand how easy is it for seizure-like behaviour to emerge. And then this informs a risk score. So essentially, the easier it is for this seizure-like behaviour to occur, the more likely, from the perspective of the data, it is that this is an individual with epilepsy. And in studies we've been working on with a number of clinical partners, we find that this approach can actually essentially give us the same level of accuracy as the entire clinical pathway that might involve several EEGs, takes up to a year on average. And we're using this information to actually develop this decision support tool that provides a report to the neurologist that provides additional information in addition to the clinical markup and the clinical interpretation of data that is routinely acquired as part of the diagnostic journey. So I think in the interests of time, I'll call it a day there. I'm really looking forward to hearing your questions and discussing further how mathematical models can help us understand the brain and ultimately improve diagnosis of epilepsy. Thank you.